This voiceover is going to cover anemia and polycythemia. Anemia is described as a deficiency in the number of erythrocytes, or red blood cells, the quantity of hemoglobin, or the volume of packed red blood cells, or hematocrit. It's not a specific disease, but a manifestation of an underlying problem. It's identified and classified by laboratory diagnostics, grouped by morphologic or etiologic classification, due to dietary problems, absorption problems, genetic disorders, bone marrow disease, or excessive blood loss. This slide is just another indication of some of the causes of anemia. In a mild state where our hemoglobin is somewhere between 10 to 12, our patients may be asymptomatic, and if we see symptoms, they might be mild. In more moderate states where the hemoglobin is 6 to 10, we may have symptoms at rest, increased palpitations, dyspnea, and fatigue. If we're in a severe state of anemia, our hemoglobin might be less than 6, and some manifestations we might see might involve multiple body systems. But we sometimes do see patients walk in through the ER or through the hospital with a hemoglobin less than 6. And because the blood loss or the deficiency has been so insidious and slow, these patients have learned to compensate well. The red blood cell function is to transport oxygen from lungs to systemic tissues, and vice versa, to carry carbon dioxide from the tissues to the lungs. The manifestations of anemia are going to vary based on the rate of development, the severity of anemia, and the presence of coexisting disease. Some general manifestations we might see are fatigue. Some of the most common cardiac or cardiopulmonary manifestations we see is going to be tachycardia, palpitations, and orthostatic hypotension. In severe cases, especially in patients with coexisting diseases, such as coronary artery disease, we might see chest pain, myocardial infarction secondary to the tissue ischemia, heart failure exacerbations. Some of the integumentary or skin changes might be pallor, itching, jaundice. Some of the CNS manifestations, we might see headache, dizziness, impaired thought processes. This is known as the anemic fog, and these patients directly related to low oxygen flow to the brain. One of the most common types of anemia is going to be iron deficiency anemia. It's typically going to develop from inadequate dietary intake, malabsorption, increased metabolic needs, and blood loss. Some of our susceptible individuals are going to be younger patients, those on poor diets, and women in reproductive years. As stored iron is depleted without restoration, hemoglobin production is decreased. Only about 1 milligram of every 10 to 20 milligrams ingested iron is absorbed in the duodenum, and 1 milligram lost per day is going to be through secretions, our urine, our feces, and our sweat. So in a normal patient, we can recoup those losses well. But if we have blood loss, increased metabolic needs, we're going to use those iron stores without replenishing them. So eventually over time, we're going to become iron deficiency with subsequent anemia. Some more specific causes is going to be chronic blood loss, patients with cancers, uterine fibroid tumors, endometriosis, lack of iron intake, not sufficient for those with higher needs. So your patients who have menorrhagia every month, where they're having the fibroids, the endometriosis, where they're having heavy periods monthly. Pregnant women who need increased iron stores for the red blood cell production, increased fluid volume for the increased flow to the placenta and the baby. Without proper iron intake, we're going to utilize their stores and they're going to become anemic. Infants who are breastfed or are getting formula that doesn't have enough iron in it, they're at risk for anemia. Small children who consume too much cow's milk, they're at risk for iron deficient anemia secondary to low absorption. People who are malnourished, people of low socioeconomic status, they might not have the funds to buy iron sources of food that have hem in it. Meat products are very expensive. Alcoholics. Alcohol might decrease the absorption of iron. Alcoholics typically want to drink versus eating. That places them more at risk for being anemic. Anything that's going to increase transient time, GI surgeries, malabsorption syndromes, and chronic diarrhea, these are going to decrease the absorption of iron in the duodenum. Your dialysis patients are going to lose blood through their dialysis circuits and through the frequent blood draws. They're going to be losing blood and subsequent iron in their blood, so they're going to become iron deficient anemic. So a lot of these patients in the early stages may be asymptomatic, and if they do have symptoms, they're going to be general. Fatigue. Some of the most common manifestations of iron deficiency anemia is going to be pallor or glossitis. Glossitis is the inflammation of the tongue. The tongue is going to be beefy, red, shiny. Cheilitis is going to be inflammation of the lips. Angular cheilosis is going to be the ulcerations of the corner of the mouth. Brittle, spoon-shaped nails. Some of these patients may develop pica, a craving for non-food products like dirt or starch. They might have CNS symptoms like headache, paresthesias, and burning sensation of the tongue. These are pictures that just depict the angular cheilosis, the spoon-shaped nails, and the glossitis, the beefy tongue, the shiny, beefy red tongue. Some of the diagnostic studies, we might do an H&P to investigate what makes them a high-risk patient. We might do a dietary recall to see, are you eating enough products that have iron in it? Their hemoglobin and hematocrit are going to be low. The reticulocyte count, which is measurement of their immature red blood cells, is going to vary. We're definitely going to see a low serum iron and a low serum ferritin. Serum ferritin is going to be the representative of the iron stores in our body. So typically ferritin is stored as iron in our liver. Okay, so if we have a low serum iron and a low serum ferritin, that's pretty indicative of iron deficiency anemia. Our serum transferrin and total iron binding capacity, those are typically going to be increased if we don't have enough iron to bind to these sites to transfer back and forth from tissues, from bone marrow. We're going to have elevations in these total iron binding capacity proteins. Our bilirubin is going to be normal. We're going to see normal levels of serum B12 and folate. And in the event we can't get a conclusive diagnosis, we might need to do some GI studies and bone marrow aspiration. This might be used to detect a GI bleed or to see if other tests have been inconclusive and if we've got a more definitive diagnosis based on a bone marrow aspiration. So treatment is going to be on investigating the cause and treating it. We're going to increase their dietary intake of iron. Hem products are typically best because they don't break down and there's better availability of it in the duodenum versus non-hem products are more susceptible to being broke down and not being absorbed. So hem products are your best, but non-hem products might be encouraged in patients that don't eat meat. In the event that the anemia is severe, patient is significantly symptomatic and they have some of the coexisting diseases, we might consider doing a blood transfusion. Some of the nursing measures we might consider in a patient who has iron deficiency anemia is maintaining their oral integrity. These patients have inflammation of the tongue, the lips, the ulcerations around the corners of their mouth. And we might consider nursing interventions to lessen their activity intolerance. Some drug therapy we might consider is always oral iron first. Some of the preparations you might see in practice is furosis sulfate or furosis gluconate. We're going to do our best to avoid enteric-coated or sustained release capsules, and this is because they break down farther in the small intestine, so there's going to be a decreased absorption of iron. Best to give it on an empty stomach. Vitamin C is going to enhance the absorption of iron, so we might want to encourage these patients to take their iron with orange juice, citrus fruits. A lot of times gastrointestinal side effects can occur, like heartburn, constipation, and dark stools. We're going to ask our patients to avoid taking iron with caffeine in coffee, tea. It's going to decrease the absorption. Dairy products, anything with calcium in it, like spinach, is going to decrease the absorption of iron. If they have to take a liquid form, it's going to stain their teeth, so need to make sure that they drink it through a straw. We want them to encourage good hygiene and to rinse their mouth after the administration. In the event they have a lot of gastrointestinal side effects, we're going to increase fluids and fiber to decrease constipation. In the event that that doesn't work, we might do stool softeners like DocuSet sodium or Colace. In the event that a patient can't tolerate oral preps or there's a malabsorption problem, we might consider doing IV or IM preps. In the event that you have to give an iron prep, we're not going to mix it with other meds. We're going to give it undiluted, no faster than a milliliter per minute, and we're going to flush with normal saline. Dextrin products have a higher risk for allergic reactions. In the event that we have to give an IM injection of iron, we're going to know that it could stain the skin and that it can be very irritating. So we're going to make sure we change the needle after drawing up the medication. We're going to use a big needle, at least 2 to 3 inches. We're going to give it via the Z-track method into the gluteal, and we're going to use no more than 2 mLs per injection. And we're going to inject it slowly, and we're not going to massage it afterwards. In the event we have to use iron, we're going to be alert for iron toxicity, such as nausea and vomiting, diarrhea, abdominal pain. Again, as we said before, because iron can be binding and constipating, we want our patients to eat high fiber foods, increase fluid intake, and utilize stool softeners. We want to make sure our patients know that it could turn their stool dark green or black, but that it's not indicative of bleeding, that it's just the breakdown of iron. Hemoglobin levels tend to increase within a few weeks of starting iron replacement. We want to make sure that these patients continue to take their iron supplements for at least 6 months to replenish their iron stores. So some nursing and collaborative management might include identifying at-risk patients or groups, teaching about supplemental iron, discussing and educating about diagnostic studies that these patients might be signed up for, and we're going to encourage compliance with any type of treatment plan. We may have to curtail the treatment plan to encourage adherence or compliance to the plan. For example, we want our patients to take iron on an empty stomach, but a lot of times if they have gastrointestinal problems like nausea, vomiting, it might be best for them to take it with some food. Even though it decreases the absorption, it's better for them to take it versus not taking it at all. Vitamin B12 or cobalamin deficiency is typically caused by a deficiency in vitamin B12 intake or poor absorption. So a lot of the times we might see a malabsorption in patients who have Crohn's disease, inflammation of the stomach, removal of the stomach, any inflammation or resection of the ileum, because this is where vitamin B12 is absorbed. Cases of pernicious anemia, where it's thought to be an autoimmune destruction of the parietal cells. We know parietal cells are in the stomach, and they secrete intrinsic factor, which intrinsic factor and acid is required for the uptake, the movement, and the absorption of vitamin B12 in the ileum. There's going to be some hereditary enzyme defects that can lead to cobalamin deficiencies. A lot of our vegans, strict vegetarians, are at risk for vitamin B12 deficiencies because the majority of what we get out from B12 is meat products. There are going to be some drugs that can lead to cobalamin or vitamin B12 deficiencies. Neomycin decreases the absorption of vitamin B12. The long-term use of histamine blockers and PPIs are going to decrease gastric acid secretion from our parietal cells, and we need gastric acid for the uptake and the absorption of vitamin B12. So typically, vitamin B12, the manifestations is going to be slow, gradual. We may not even notice them at first. There's going to be a lot of GI symptoms, weight loss, weakness, diarrhea. We might see the pallor, and we might see the glossitis, the beefy red tongue, the sore tongue. And we might see the angular chelosis, the ulcerations around the corner of the lips. Typically, patients with vitamin B12 deficiencies, we're going to see neuromuscular complications. In addition to the vitamin B12, that it is a substrate that's going to help with red blood cell maturation and DNA synthesis, it also has a little bit to do with myelination, with action potential through our axons and our neurons. So if we have a deficiency in vitamin B12, we're going to see some neuromuscular manifestations, fatigue, muscle weakness, paresthesias of the hands and feet, ataxia, and impaired thoughts. Some of the diagnostic studies that we see, we're going to see a CBC. We're going to see a drop in the hemoglobin and hematocrit. In the event that this is a pernicious anemia and where we suspect that it is an autoimmune condition, we're going to do an anti-antitrypsin factor antibody test, and that would be positive. In the event that we don't have enough hydrochloric acid for the uptake and absorption of vitamin B12, we might have to do a gastric analysis. Patients who have vitamin B12 deficiencies, especially pernicious anemias, are at risk for cancer. So we might at some point need to do a gastric biopsy or endoscopy procedures. Because vitamin B12 is a substrate in DNA synthesis and red blood cell maturation, when we have deficiencies in vitamin B12, that DNA synthesis cannot occur. And as a result, there's going to be buildups of specific metabolites known as MMA or homocysteine. So in somebody who's got a vitamin B12 deficiency, we're going to see elevations and increases in these MMA and homocysteines. There is a specific test that can kind of evaluate the lack of intrinsic factor in somebody who's got vitamin B12 deficiency. It's a test that's not utilized now in a lot of labs because they don't have enough resources to do it. But it's going to be a 2 or 3 step test. These patients are going to be NPO except for water for 12 hours, and then they're going to get an oral dose of vitamin B12. 1 to 2 hours after this oral dose, they're going to get an IM injection of vitamin B12. And for 24 to 48 hours, they're going to collect a urine sample that they're going to keep on ice. So they want to see an elevation in the vitamin B12 in the urine, which means that the vitamin B12 was taken up in the ileus, or there was enough hydrochloric acid to move and help with the absorption. In the event that the urine for vitamin B12 is low, they might need to do a repeat test after they've given it with with an intrinsic factor, just to see kind of where they're at. In very unclear cases, very rare cases, they might need to do a bone marrow aspiration or biopsy. So the treatment for vitamin B12 is going to be good nutrition. In the event that this is a dietary problem, we're going to encourage foods high in vitamin B12. If it's a significantly symptomatic case or the anemia is so severe, We may need to do a blood transfusion, especially if these patients, they have coexisting conditions like cardiac disease. Because vitamin B12 deficient patients are at risk for gastric cancer, especially if they have pernicious anemia, we're going to need to do a follow-up. We're going to need to monitor their B12 and folic acid levels. Because of the neuromuscular conditions and these patients are at risk for injury, we're going to do what we can to protect them from burns and trauma. And even though we can adequately reverse somebody's anemia, if somebody's had vitamin B12 deficiency anemia for a long time, a lot of times we may not be able to reverse their neuromuscular complications. So we can reverse the anemia, but we may not always be able to reverse the neuromuscular complications. If we have to move to drug therapy, we might use oral. Now, if a patient has pernicious anemia or they lack intrinsic factor, for example, if they've had their stomach removed, we don't have parietal cells, we don't have acid content in the stomach, and we don't have intrinsic factor. So it's not going to be of use to give somebody an oral medication for vitamin B12 because it won't be of use. We need to make sure that if they can take it orally, that they avoid taking alcohol with it because it interferes with the absorption. In the event that a patient cannot take oral B12, they need to do IM injections, typically for 2 weeks, then weekly until their hematocrit is normal, and then we're going to do it monthly for life. We need to make sure that the injection is given IM or deep subcutaneous because it's irritating. They may experience temporary burning at the injection site. And there are capabilities to do intranasal vitamin B12. It's given once weekly. They take at least 1 hour before or after hot liquids or foods.